Hey guys, it's Medicosis Perfectionalis one more time. We continue our discussion about the great playlist of pulmonology. In the previous video, we have talked about rhinosporidiosis. Today we'll talk about rhinosinusitis. What does rhino mean? Nose. What does itis mean? Inflammation. What does sinus mean? Sinus, your paranasal sinuses. And there are four main groups of them. This is called frontal. The one next to your eye is called ethmoid. This one is called maxillary. And this one is called sphenoidal sinuses. Because these sinuses, some of you think that they are empty boxes. Wrong, they are lined by epithelium because epithelium covers and lines every part of your body. And this epithelium, like any epithelium, can get inflamed, causing rhinosinusitis. So this is the topic of today's video, and let's get started. Let me help you by answering the case of last time, and this is case number 8. 45-year-old Caucasian male, present to your office for his chronic condition. When he was a child, he had lots of pus and the medical history of bowel obstruction due to meconium ileus, pancreatic insufficiency. He's taking ivacaftor and Dornase alpha. On speculum exam, there is bilateral nasal polyps. On CT scan of the chest, there is bronchiectasis. Which of the following organisms are more likely to be involved in the respiratory infection at this age, carries poor prognosis, decreased survival, and will cause you to take the patient's name off the transplant list? And here are your choices. Now pause, and the correct answer is, first of all, this is what? This is cystic fibrosis. How do you know? Caucasian, because cystic fibrosis is commoner in patients or people with Northern European descent. Lots of pus in the lung because of bronchiectasis, meconium ileus because of the thick secretions, pancreatic insufficiency. That's why we call the disease cystic fibrosis, because in the lungs there are no cysts and there is no fibrosis most of the time. The cystic fibrosis is named after the pancreas. There are cysts in the pancreas, there is fibrosis in the pancreas. Ivacaftor is a CFTR potentiator. Dornase alpha is a mucolytic because the secretions are so thick. Which of these organisms carry poor prognosis at this age, decreased survival rate, and will lead you to take the patient's name off the lung transplant list? And the answer here is Burkholderia cepacia complex. In the good old days, this was called Pseudomonas cepacia. No more. Today it's called Burkholderia cepacia complex because it's more than one bacteria. How about Pseudomonas? Yes, Pseudomonas also carries a poor prognosis, but I was very specific. At this age, poor prognosis, decreased survival, and will lead you to take the patient's name off the transplant list. This is Burkholderia cepacia complex. It's a horrible bacteria. So let me help you by mentioning some of the organisms that are commonly seen in cystic fibrosis patients. First, you have Staph aureus. Please don't ever forget that. Then you have other stuff such as Haemophilus influenza, such as the great Pseudomonas. You have some enteric gram-negative bacteria such as Proteus, E. coli, and Klebsiella. You can have other stuff such as this nasty Burkholderia cepacia, such as other Algalegenes and some other stuff. And of course, Aspergillus is common in cystic fibrosis. So, Staph aureus, Haemophilus influenza, Pseudomonas, Proteus, E. coli, Klebsiella, Burkholderia, and Aspergillus. Cystic fibrosis as an exam question is loved by every professor on the face of the planet. Now let's talk about rhinosinusitis. Inflammation of the nose and paranasal sinuses. So, you have obstruction of the sinus drainage. When there is obstruction, there is stagnation. There is less flow. Bacteria love stagnation. They will just settle here and do their thing. Inflammation of the paranasal sinuses. You will have pain over these areas. Pain on your forehead, pain at the side of the eye, pain on your maxilla or upper jaw, and here pain in the sphenoidal. You can have headache or something. 4 types: acute, subacute, chronic, and recurrent rhinosinusitis. Typically maxillary sinus, this is really important, which drains against gravity. because it has to drain upwards to the nose, upwards to the nose. And this is against gravity. If it's against gravity, it's hard. If it's hard, it's going to lead to stagnation. If stagnation is going to lead to bacteria, you get the idea. So, you have superior nasal meatus, middle meatus, and inferior meatus. The superior meatus, wait a sec. What's a meatus? Okay, in your nose, let's say that this is your lateral nose. You have 3 turbinates, also known as choanae. So these choanae are here, superior, middle, and inferior. Below each one is a meatus. So this is superior meatus, middle meatus, and inferior meatus. Superior meatus drains what? Sphenoid and posterior ethmoidal nasal sinuses. Middle meatus drains frontal, maxillary, and anterior ethmoidal. Inferior meatus drains the nasolacrimal duct, and that's why, my friend, when you cry, you have a runny nose at the same time, because your nasolacrimal duct, beautiful, your nice precious crocodile tears end up in the nose. Please be specific, the inferior nasal meatus. And that's why if you have epistaxis, which is bleeding from the nose, you can end up bleeding in your tears. You can have blood in the tears. Oh my goodness. Yes, it's possible if you understand the anatomy. Which sinus is commoner? It depends on your age. If you're an adult, it's usually the maxillary, and the mnemonic maxillary for the mature. Children, most common is the ethmoid sinuses. So adults will complain of pain at the upper jaw here. Kids will complain, if they can talk and complain, pain next to their eyes, on the medial side of the eye. Causes of rhinosinusitis, infectious or non-infectious? Let's start with infectious. The most common cause is not bacterial, it's viral, especially rhinovirus. Please don't ever forget this. Rhinosinusitis, rhinovirus. And next we have bacteria. Bacteria infection is usually superimposed over a viral infection. We start with a viral, then we have a secondary bacterial infection. So you start with a virus, then a secondary bacterial infection. Which bacteria? You have the strep pneumo, the non-typable Haemophilus influenza, and the Moraxella catarrhalis. This is the famous triology or triad of bacteria you have to memorize. Strep pneumo, non-typable Haemophilus influenza, Moraxella catarrhalis. Why non-typable? Why are you that specific? Because now we have a vaccine against Haemophilus influenza B. So Haemophilus influenza B, back in the good old days, which were not so good, was the most common. It was one of the most common bacterial causes of acute rhinosinusitis. Today, no more, thanks to the vaccine. Please vaccinate your kids. Today, the common bacteria is the non-typable, because we have no vaccine against them, Haemophilus influenzae. So, okay, we will memorize those nice famous 3. Strep pneumo, Haemophilus influenzae, Moraxella catarrhalis. Is there anything else? Yes, the nasty anaerobes. The Staph aureus, especially nosocomial infection. Hospital is full of MRSA, like a lot. Systemic fungi such as mucor or aspergillus. Mucor and rhizobus, please, mucor, remember diabetes patients. So for diabetes, remember the mycor species. What else? Teeth problem, because your teeth here, okay, are in your jaw, so they are very close to the maxillary sinus. We're done with the infectious causes. How about non-infectious? Allergic rhinitis, air pollution, barotrauma. Baro means pressure, trauma due to pressure. Scuba divers and ventilator-induced barotrauma, which we'll talk about later. Cigarette smoking, they damage your ciliary escalator or the cilia in your nose. Anatomical problems in the nose, such as rhinoscleroma, which we have talked about in a previous video in this great playlist of pulmonology. Septal deformity, choanal atresia, and of course we have a video about choanal atresia, the famous baby who gets pink when crying and blue on breastfeeding. What are the causes of recurrent rhinosinusitis? Asthma, cystic fibrosis, and immunosuppression. Cystic fibrosis is one of the causes of chronic rhinosinusitis and maybe acute. And if you have rhinosinusitis due to cystic fibrosis, as a result, you will have nasal polyps. So now you have inflammation or infection in these sinuses, which are empty boxes, not so empty, in your face. Now they are not empty. They have the epithelium, which is normal, and they have all of these inflammatory debris, which is abnormal. Symptoms, can you guess them? Thick nasal mucus, absolutely, because all of this gunk is ending up in the nose. Plugged nose, no wonder. Congestion, absolutely. Facial pain or headache, because these are boxes in your skull. And this pain will worsen when you lean forward and bend your face downwards. Fever, it's a freaking infection. Poor sense of smell, of course, because it's the nose. Because let's talk about fever again. You remember the cardinal signs of inflammation? Redness, hotness, swelling, pain, loss of function. So hotness is fever, baby. Cough from post-nasal discharge, tooth pain if it's the maxillary sinus, symptoms of a complication, because if this infection or inflammation is your nose, it can spread around your eye, called periorbital cellulitis, to your meninges in your brain, called meningitis, to your middle ear through the eustachian or auditory tube, called otitis media. The patient can come complaining of one of these symptoms, and the original source is not the meninges, the periorbital, or the middle ear. The main source was the paranasal sinus. Beware. What are the signs? Okay, what's the difference between symptoms and signs? Symptoms have a Y, so you, as a patient, will describe them. Signs, they have the I. I, as a doctor, will discover them because I'm genius. I'm super sophisticated to the point of being stupid. Sputum is gonna be green because it's an acute sinusitis, and acute is caused by neutrophils. Why is neutrophil related to green? It's a very important question, and I want you to let me know the answer in the comment section. Thick mucus or sputum may contain pus or blood. It's infection, baby. Pain on percussion tenderness, which means when you tap on the patient's bones or these sinuses, you're trying to tap on them, called percussion, you find tenderness. What's the difference between pain and tenderness? Pain is a symptom, tenderness is a sign. Over the affected sinuses, frontal, ethmoidal, sphenoidal, or maxillary, it depends on the location. Pain is usually localized to the involved sinus, might worsen if the patient bends over or when lying down because there is more pressure on the sinus, called gravity, baby. How to differentiate between toothache and sinusitis? The pain in sinusitis is usually worsened by tilting the head forward and with Valsalva maneuver, it's called gravity. Tooth pain is not gonna matter, but when you bend forward, when you have a sinusitis, it's gonna hurt more because gravity pulls all of the inflammatory debris downwards. And these are boxes in your skull. Boxes have stuff in them. They create pressure. It's called physics. Deviated nasal septum if it's only in one side. Complications, we have spread of infection and we have anosmia, which means loss of sense of smell. Let me ask you a question. What do we call it when you have loss of sense of taste? There is a crazy name like anosmia. Please let me know the answer in the comments. Spread of infection, okay, use your anatomy sense. You have the middle ear opening into those nasal meatuses, so we will have otitis media, spread of infection upwards through the eustachian tube to your ear. This eustachian tube is also known as auditory tube. And which part of the ear? It's the middle ear. That's why we call it otitis media, middle ear. If it was the external ear, we call it otitis externa. Sinusitis, ethmoidal vein thrombophlebitis, which is kind of here next to your eye. When you have ethmoidal vein thrombophlebitis, you will have transmission of infection into the eye socket, and then you'll have spread of infection into the orbit and periorbit, called periorbital cellulitis, which can cause loss of vision. This is an emergency. Orbital cellulitis is horrible. Sinusitis can lead to facial bone or spread to facial bone, leading to osteomyelitis. Sinusitis, if it happens in the sphenoid or the ethmoid sinuses, this is called the dangerous triangle of the face, and this is absolutely horrible. Here is your dangerous triangle. It's like this. Infection in this triangle can spread easily, even to your cavernous sinus. And this is absolutely horrible. You know, antibiotics are miraculous drugs. We used to struggle with these infections before. Now, thanks to antibiotics, more than 98% of infections are treatable. But this is an ugly exception, the dangerous triangle of the face. even with antibiotics, because it can spread anywhere, even to your cavernous sinus on one side. You know what's happened next? It's gonna go to the cavernous sinus on the other side in about 2 days or less. This is absolutely horrible. If I have to choose, I would like to choose CLL, chronic lymphocytic leukemia, stage 0, any day of the week over the horrible cavernous sinus syndrome. Well, this is a leukemia, but it's stage 0. It's asymptomatic and it's controllable. Cavernous sinus syndrome is horrible. What else? Spread of infection to the meninges causing meningitis, and to the brain causing encephalitis, brain abscess, and even subdural empyema. What does empyema mean? Collection of pus in a tissue. We have pleural empyema if it's here in pleural cavity. We have subdural empyema if it's under the dura or above your brain. And please don't ever forget empyema with pyemia. What does pyemia mean? Don't say pus in the blood. Stupid. It's a septic embolus in the blood. Not pus, because pus doesn't float in the blood. Stupid. I'm sorry. Let's talk about cavernous sinus thrombosis. Symptoms: sudden onset of unilateral periorbital edema, headache, photophobia. Oh, it's meningitis. Wait. Orbital swelling. It's not meningitis. Proptosis, your eyes bulging forward. Chemosis, swelling of the conjunctiva. Be very careful. And you can have neurological manifestations, motor and sensory. Let's talk about the cavernous sinus. The cavernous sinus has some contents. It has the nerves. 3, 4, please skip 5 and let's talk about 6. Why did you skip 5? Because 5 has 3 branches. What is 5? First, it's the trigeminal nerve. This is 5. 5 has 3 main branches. The ophthalmic branch, also known as V1. V for 5 in Roman numerals, and 1 is first branch. So this is the ophthalmic. V2 is the maxillary branch, and V3 is the mandibular branch, which is motor, it has motor stuff. So forget V3. It's not involved in this condition, but I need V1 and V2 inside the cavernous sinus. So symptoms are going to be related to nerves 3 and 4, V1 and V2 branches of 5, and 6. So let's talk about the motor functions. You have the cranial nerve palsies. Alright, but since V1 and V2 are not motor, so let's focus on 3, 4, and 6. Okay, let's talk about third nerve, the oculomotor. Paralysis of the oculomotor, down and out, ptosis, mydriasis. What do you mean by down and out? Okay, here is your eye, and here's your nose. You're looking like this, down and out. Here's your eye. Looking down, you're looking out. This is third nerve pulse. Ptosis, which means your lid is down. Okay. Mydriasis, which is opposite to miosis. It has a D, so it's dilation of the pupil. You have blown pupil like this. They are blown up. So ptosis, mydriasis, down and out. How about the 6th cranial nerve, the abducens? Abducens, it abducts the eye. What do you mean by abduct? Abduct is this motion to outside, to the outside. So injury to this nerve will lead to you to look inwards. Also known as medial deviation of the eye. Also known as adduction of the eye. We're done with the motor. Let's talk about sensory. Remember V1 and V2? These are sensory, baby. So V1, ophthalmic branch. Ophthalmic branch innervates this part. So these parts around the eye. Then we have the maxillary branch. And the maxillary branch innervates these parts. Also the ophthalmic, which is V1, which innervated around the eye, is responsible for the corneal reflex. When I touch your cornea, you blink. If you have a cavernous sinus thrombosis, this corneal reflex is lost due to an injury to V1, which is the ophthalmic branch of the trigeminal nerve. If there is cavernous sinus thrombosis or a syndrome inside your skull, are you gonna feel pressure? Yes. Why? Due to increased intracranial pressure. This is called intracranial hypertension, which can lead to Cushing reflex. I have an entire video about Cushing reflex, and this is really important for your exam. So, increased intracranial pressure will push the eye forward, papilledema, and you have edema in the eye and proptosis and all of this stuff. And you will have retinal hemorrhage because of the pressure. They can rupture the retinal blood vessels. If you have a cavernous sinus thrombosis on one side or a cavernous sinus infection, it can spread to the cavernous sinus on the other side within 24 to 48 hours. Chronic sinusitis. So we're done with acute. Let's focus about chronic. You have chronic inflammation of the paranasal sinus persists for at least 12 weeks to have your diagnosis. Causes different organisms. So Staph aureus and Staph epidermidis, Pseudomonas, cystic fibrosis, granulomatosis with polyangiitis, other gram-negative rods, anaerobes, and fungi. In chronic rhinosinusitis, you don't see the famous three bacteria, the triad. You remember those three bacteria of acute rhinosinusitis? We have strep pneumo, non-typable Haemophilus influenza, and Moraxella catarrhalis. Clinical picture of chronic rhinosinusitis. We have 2 C's, 2 H's, 3 pains, loss of 2 sensations, and then we have signs. 2 C's, congestion and cough. And then we have 2 H's, hoarseness and halitosis. Hoarseness is when your voice is hoarse. Halitosis is bad breath. 3 pains, pain in your nose, dental pain, head pain, which is known as headache. Loss of 2 sensations, taste sensation and smell sensation. Smell sensation, loss of smell sensation is called anosmia. Loss of taste sensation is called, please let me know in the comments. And then the sign, pressure palpation on or percussion of the sinus. So, associations of chronic rhinosinusitis. Nasal polyps, absolutely. Chronic inflammation. Cystic fibrosis, yep. Cystic fibrosis, thick secretion. Chronic inflammation, chronic sinusitis, leading to the development of nasal polyps, usually bilateral. Asthma, in 50% of patients without nasal polyps and 80% of patients with nasal polyps. Which sinuses are most commonly involved in chronic rhinosinusitis in this order? Anterior ethmoid, maxillary, posterior ethmoid, sphenoid, and frontal sinus. How to diagnose chronic rhinosinusitis? It's a clinical diagnosis through the history and the physical exam. It's the tenderness or percussion. When you percuss those sinuses, it hurts. If symptoms persist, you can do an X-ray. Please order a sinus view. CT scan, also a sinus view. What a view. It's called a sinus CT, which is of course better than the X-ray. Direct visualization by speculum exam or even endoscopy. If you are struggling to learn about microbiology and all of these nasty organisms, Legionella, Mycoplasma, Pseudomonas, Rhinovirus, etc., check out my friend's website called Picmonic, Pictures and Mnemonics about medicine. See the link in the description below. Now we're talking about treatment of the acute rhinosinusitis. First, watch and wait. Why? Most of them are caused by viruses. You remember which virus? Rhinovirus. If they persist, they are probably a secondary bacterial infection. Alright, so you try non-steroidals, steroid, nasal irrigation, decongestant nasal spray, antihistamine, and then if symptoms persist or didn't improve, add the antibiotics. Every 7 days after the introduction of antibiotics, if the patient doesn't improve, you switch the antibiotic into the other antibiotic. You wait another 7 days and then you switch. Another 7 days. If the patient didn't improve, you switch. What is the famous or the gold standard in treatment of acute rhinosinusitis? Amoxicillin clavulanate. Don't ever forget that. If there's, I need you to remember 3 facts from this video. Number 1, acute rhinosinusitis is mostly caused by a virus called rhinovirus. If it's bacteria, 3 famous bacteria: strep pneumo, Haemophilus influenza, Moraxella catarrhalis. The second fact, spread of infection to your ear, otitis media, to your cavernous sinus, to everywhere, even periorbital cellulitis. And number 3, the drug of choice is amoxicillin clavulanate. Why do we add clavulanate? It's a beta-lactamase inhibitor because amoxicillin is beta-lactamase sensitive. We have to add this clavulanate to protect the amoxicillin from the beta-lactamase secreted by the nasty bacteria to try to resist you, called resistance. If the patient is allergic to penicillin, the patient is going to be allergic to amoxicillin. It's called common sense. Try macrolides, fluoroquinolones, or tetracycline. Pay attention. Sinusitis can lead to orbital cellulitis, and this can spread to cavernous sinus syndrome. On the other hand, nasopharyngeal carcinoma caused by the Epstein-Barr virus can also lead to cavernous sinus syndrome. And these 2 facts are extremely important. So let's have a case. This is case number 9, and it has 2 questions. So where are the previous 8 cases? They are in the previous videos, honey, in my playlist called Pulmonology or Pulmonary Medicine. So case 9, 34-year-old Norwegian man comes in complaining of recurrent episodes of runny nose, hemoptysis, nasal discharge, and even blood in the urine. Ooh! Physical exam was significant for a saddle-shaped nose. The patient felt pain when you pressed your finger against his facial bones. Strawberry gingivitis was noted, but palpable purpura was absent. Urinalysis revealed RBCs in the urine. A biopsy of a blood vessel revealed muscular artery vasculitis. A renal biopsy revealed crescentic glomerulonephritis. You started the treatment by using the drug of choice. 4 weeks later, the patient complained of frequency, urgency, burning dysuria, and hematuria. There was a low-grade fever and suprapubic tenderness. Urine cytology revealed some cells. What was the name of the drug that you prescribed? This was the first question. The second question is, which of the following would have prevented this complication? Please let me know the answers down below in the comment section, and you will find the answers in the next video. So please subscribe and save my pulmonology playlist. Love you guys. Thank you so much for watching. Please subscribe and join the tribe. Hit the bell to get notified. Follow me on Facebook. I have more than 100 cases there. Please support this channel on Patreon, and I will send you my notes. I have cases, I have PDFs. All of these notes for these videos, all of the slides are available for links to directly download them and keep them. They are for you forever. This is Medicosis Perfectionalis, where medicine makes perfect sense. As always, be safe, stay happy, and study hard. Until next time.